Okay, take two. I think that we're recording. Hopefully we are. So, sorry about that. All right, so we were talking about the muscles of the pelvis. Just quickly, we also talked real quick about this outline, how this is a current outline, but you can go to the ARDMS website and look. It's under get registered and then preparation and then the course outline for the test outline for OBGYN. So within anatomy and physiology of the normal female pelvis, we've got those muscles that you guys learned about.
Hey, Jen,
Yeah.
are we supposed to see it on here too?
Oh God. Yeah, you know what? You would think. Pause. Okay, hopefully now you can see what I was trying to show you. Can you see it?
Yes.
Okay, perfect. So just quickly, the muscles of the spine of the female pelvis that you were making your model of way back in the beginning. Are, we can find them. Okay, there we go. If you can even see this, the levator ani muscles, those are the big ones. Those are the ones that you see when you're doing a pelvic exam that you just need to be aware of that they're there. And they are made up of the puborectalis, coccygeal, and iliococcygeal. So this one, and this one. And then you have the piriformis muscle, which goes way up into the, it goes up to the lateral side of your buttock. I know this because when I walk, I get pain there, and a variety of others. So that's the point of that. It's just remembering those muscles. They are normal. You want to make sure that you are not mistaking those for anything ominous. Pelvic landmarks being the pubis symphysis, which is the bone anterior to the bladder. A lot of times you have to be way low, like way down at that bone level to see the uterus. And then you have, or the cervix, and then you also have your uterus and your cervix and your ovaries and your blood supply. So perfusion and function, if you remember correctly, we went over that whole menstrual cycle. That was a combination of the endocrine cycle and the ovarian cycle, which then led to the changes in the endometrium. So the menstrual cycle, sorry, hold on, endocrine. So who remembers this? Probably never want to see this again after having to do that poster. But let's see if I can get something at least big enough for you to see. So you have within the endocrine cycle, you've got the follicular phase, the luteal phase. And let me go back because there's better explanation here. There's the hormones that are being released from the pituitary. Okay, that's better. So you have the pituitary and the ovarian hormones level fluctuating. So in the early days, day zero being the first day of your period, you have pretty constant levels of FSH. Anybody remember what that is? Follicle stimulating hormone. And estrogen and LH, which is luteinizing hormone, and progesterone. But then by day 4, you start to see a little bit of changes. Your estrogen increases, you start to feel better. And then you've got this kind of rapid drop off, luteinizing hormone peaks. And what the luteinizing hormone does is calls to the ovary to ovulate, to produce an ovum. So this is all happening simultaneously. By day 14 is about the time ovulation happens, and then one of two things can happen. Either you have fertilization or not. If you have fertilization, then that ovum that then becomes a corpus luteum hangs around and starts producing progesterone. And that's what tells your body not to bleed. It tells it to hold on to that blood, that developing zygote is going to need it to keep it around. And then obviously, you don't get your period, and by day 28, your body starts creating, or actually the chorion of the newly created embryo will start making HCG, and you take a pregnancy test and voila, you're pregnant, right? So otherwise, if no conception happens, then your body, the corpus luteum will start to involute and go away, and then you'll get your period. There's nothing telling your body to keep that blood. And then, does anybody remember the names of these phases? So you've got the Graphian. Remember when it's all involuted and going away, the Graphian follicle. Let's see. Graphian follicle. So yeah. So this whole cycle then goes that you've got your primary ovum, and then remember your ovaries start to mature one egg. They take turns every month, they alternate. So one of the follicles begins to develop, becomes mature. That's called the Graphian follicle, the one that's been chosen to ovulate is the Graphian follicle. Then you've got this liberated ovum, ruptured follicle, early corpus luteum, then the corpus luteum, and then the corpus albicans, which is just like a little piece of calcified peripheral part of that follicle that remains. So that's that. Now, at the same time, all of this is happening, this endometrium cycle is happening. So you've got on day 1 of your period or day 0, let's say, you've got a thickened endometrium, and then you get your period and you bleed, 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 bleed. And then on day, days like 4, 5, 6 or whatever, if you were to do an ultrasound, you would see a very thin endometrium. And then it slowly starts to build again in preparation for that fertilized egg. So by days 22, 20 to 26, you've got that very thick very thick endometrium, and that's where you go into the menstrual phases. So let's remember what those phases are called. So just remember, follicular, ovulatory, and luteal are phases. Those fall under the endocrine phases. But then you've got the, let me see.
Is it like the proliferative?
Yeah,
Is that it?
yeah, that's the one I'm looking for. I'm just looking for a chart for you, so that follicular menstruation. This is giving me, oh, here we go. Here we go. This is good. So this puts everything in one chart. So this is perfect. So your ovarian cycle, you go in the first part before ovulation, you have follicular, then you have ovulation, and then you have the luteal phase. The uterine cycle goes from the proliferative phase to the secretory phase. And so for looking at it from an ultrasound standpoint, remember you had the 3-line sign. So this here is early proliferative, I believe. And then the thickest one being secretory, like this here, very thickened. And when you see an endometrium that's thick like this, it's normal if they are of menstrual age or childbearing age. It's very normal to have a, here we go, to have a thickened endometrium like that. So this 3-line proliferative phase, followed by the thickened endometrium of the late proliferative phase, and then the thickest at the secretory phase. So that all goes out the window then when a woman is postmenopausal. They should not have a thickened endometrium. That is a sign of pathology. So anybody remember the whole thing with the pediatric GYN? It's not a difference in the size so much, although their uterus is a little smaller, but it's the ratio of the size of the cervix to the uterus. So pre-pubertal, let's see, or pre-menarche is really the terminology. premenarchal uterus is going to have sorry, I was hoping that it would give us like an image. So it says in neonates, the uterus is prominent, measuring 3.5 centimeters in length, 1.4 centimeters in width, echogenic, endometrium line. Cervix is thicker than the fundus, with the fundus to cervix ratio being about 1:2. So that's what I was trying to get to. The prepubertal uterus is tubular with a length of 2.5 to 4 centimeters, thickness of not more than 1 centimeter. But what happens at puberty is that the adult configuration happens and the fundus grows, so that the actual uterine tissue grows, and that fundus to cervix ratio becomes 2:1 to 3:1. So this uterine length varies between 5 and 8 centimeters with a width of 1.5 centimeters, and then the endometrial thickness varies with the menstrual cycle. So incidentally, regarding neonates, it's not unusual for a neonate to have hormones left over from the mother, and sometimes in a female neonate, and then sometimes they might even have a little blood, but that goes away. So it's that ratio of cervical length to uterine length that dictates a pre-menarchal versus a menarchal uterus. All right, false pelvis. That's the area superior to all of your organs. So if you remember when you made your models, the true pelvis is like kind of like the bowl. It's kind of like this bottom portion that holds all of those organs in, and the muscles of the pelvic floor, which were those levator ani muscles, kind of is what stops your organs from falling out the bottom when you need to bear down. Like if you were to do a Valsalva or cough or sneeze or use the bathroom. So the false pelvis is that area above it, more like where your hip is, and that's got the iliopsoas muscle, which makes up the pelvic sidewall, and the iliacus, which also makes up the pelvic sidewall. Now, your true pelvis is that line between the two. Let's see, we can see it. It is called the linea terminalis, and it's this right here. So organs in here, linea terminalis is right where this, what is this bone called? The ischium, right where this bone begins. That's the false pelvis, divided by this point called the linea terminalis. So within the true pelvis, you have the obturator internus, piriformis, levator ani, which includes these three muscles, and then the coccygeus. So we kind of quickly went over those, but obturator internus makes up the pelvic sidewall. Piriformis makes up the posterior lateral wall, which makes sense because It's in the back to the side. And I'll tell you, when you get old and you start to walk, sometimes that piriformis muscle can ache. So it makes sense that easy way to remember where that is, posterior lateral. So kind of goes up. This. Levator ani makes up or has three muscles that make that group up: pubococcygeal, puborectalis, and iliococcygeus. And they are this muscle group that makes up such like a sling to hold your bowels and your organs in. And then they're kind of named for pretty logically. Like puborectalis would be this muscle that comes around like a sling, those openings. All right, pelvic landmarks. You've got your ilium. That's the word I was looking up for, not ischium, I guess. Ilium. These bones of the spine here, the lumbar spine, the sacrum, the coccyx, more parts of this, more parts of the hip, the acetabulum. This bone is the pubis, obturator foramen. Any foramen is a whole. Ischium is here. This is that pubic symphysis I was talking about, how you can feel that bone way down low, below or inferior to somebody's bladder. Sometimes that's a landmark that you have to look for. Top part of your hip here, iliac crest, this greater sciatic notch, ischial spine, lesser sciatic notch, femur, having the greater trochanter and the lesser trochanter. Then you've got your uterus. You've got your vaginal canal leading up to the cervix, leading up to the uterus, then to the fallopian tube, or sometimes called the uterine tube, and then the ovaries are here. So the parts of the vagina, the most inner part is the mucosa. Then you've got the inner, so you've got that lining. That inner lining is the mucosa, which makes sense because that's where mucus is made to provide lubrication. Then you've got that middle layer, which is the muscular wall, because it is a muscular tube. You've got the adventitia, which is that outside covering. And then also the vagina has rugae, kind of like the stomach does, so it can expand. Because if it didn't expand, a baby could never make its way down. Then you've got these lateral openings here. Those are called the lateral vagina fornix, or the fornices for plural. So a lot of times when you're doing a trans-vag ultrasound, your probe actually goes up into these fornices. That's why when you look at a transvaginal image, that's why a lot of times you can see the cervix because it's kind of sitting in here or sitting in here. So that explains that. Then you've got, so the external os of the of the cervix is the opening to the vagina. And then you've got an internal os, which is the opening into the uterine cavity. When you're measuring a cervix, let's say for OB, you're measuring from the inner os to the outer os. That is the cervical length. Okay. Then you've got the uterus, which also has layers. The innermost cavity is the uterine cavity. You've got the innermost layer of the uterine wall, which is the endometrium. That's the one that grows and shrinks with the endometrial cycle. Remember, does anybody remember the name of the arteries that shed? I used to tell you, don't let them, don't spiral out of control when you get your period. They were the spiral arteries. So yeah, the spiral arteries are the ones that bleed and shed. Then you've got your thickest layer, which is the myometrium. Then you've got your most outer layer, which is the serosa. And that's going to be important when determining fibroid location. Then the corners, you've got the cornua, which means horn. So you've got these cornua. Then into the uterine tube. And the uterine tube is made up of, remember there was the interstitial. Let's see if we can get the uterine tube, the names of the parts. So we had the isthmus, the ampulla. This is saying fertilization, infant, wait a minute, I don't like that one. How about this one? The isthmus, the ampulla, the infundibulum, and this fimbria. There's little, like, almost like little fingers that accept, kind of like suck in and accept that ovum when it's released. And obviously this is the ovary, and this is the ovarian ligament. And if I had just gone one slide more, it would have been right here. But at any rate, here it all is again. So this skinny ligament is the ovarian ligament, and then you've got this broad area that's like all of this, and it goes way up here. It covers all of this. That's the broad ligament. Okay. And then you can see from this part of the image that the bladder sits right on top. And you've got these round ligaments here that are supporting the fundus, kind of anchoring that fundus. Okay. Ovaries suspend from the utero-ovarian ligament and lie adjacent to the ampullary end of the fallopian tube. So this end here, and the fallopian tube arises from the cornu of the uterus and is rarely visible. So sometimes when you're seeing on ultrasound a structure lateral to the, like in between the uterus and the ovary, it's easy to think that it's the fallopian tube, but it's not. It's the ligament that you're actually seeing. But that ligament is helpful because you can follow it out and then find the ovary. Uterine size is dependent on age and parity, and everybody knows parity means what? How many children, live births? Live births, actually there's a caveat there, because even if it's a stillborn baby, if it was over 24 weeks, that still counts. So I'm sorry, I'm getting my terms mixed up. Gravida is how many pregnancies. That's gravida is how many pregnancies, parity is how many live births, right? Gravity, even if it's a stillborn and over 24 weeks, that still counts towards gravity. As well as miscarriages or abortions, whether they're therapeutic or spontaneous. It's just, gravity is just how many times have you been pregnant? Parity is how many births. And then you've got other terms like prima gravida, which is your first pregnancy, multigravida, which means you've got more than one. Anyway, getting back to uterine size, dependent on age and parity. So nulliparous, never having had a child, the uterus is usually 6 to 8 centimeters in length, 3 to 5 centimeters in width, 3 to 5 centimeters AP. After having one child, it can grow, or not necessarily grow, but it stays just like a balloon that you've blown up and then let out, how it stays a little stretched out like that by about 2 centimeters. So those original values increase by about 2 centimeters. So 8 to 10 in length, 5 to 6 in width, and 5 to 6 AP. Multiparous, ooh, come back here. Multiparous, sorry. So with each additional child, that size can increase 1 to 2 centimeters in length. Premenarchal, meaning before a girl has her first period, it should only be 1 to 3 centimeters in length, a half a centimeter to 1 centimeter wide. And then after having their period, we're back to, that's the same as this nulliparous here, 6 to 8 by 3 to 5. Postmenopausal, it shrinks again because the body operates on that use it or lose it principle. You don't need it, it atrophies a little bit. So it shrinks down to 3.5 to 5.5 centimeters, 2 to 3 centimeters width. Now there's a caveat to that. Somebody who has had a bunch of C-sections, sometimes their uterus where that incision was can fuse to other parts, like say the bladder. So it's not mobile anymore. So it kind of stays up in that enlarged position. So that is not abnormal. So if you're doing somebody who's had multiple C-sections and their uterus is huge, just make sure you notate that they've had several C-sections. The position. So the version is the uterine body lie in comparison to the vagina. And the flexion is the uterine body lie compared to the cervix. So verted is tipped, flexed is bent. So let's look at anteverted versus anteflexed. So this one looks pretty good. So the normal position kind of goes forward like this. And the normal, I'd say, I don't want to say normal because the other ones are not abnormal, but the most common one is anteverted. And then if it folds in like this, almost like a right angle, that's anteflexed. And then you can have the same thing, how it's retroflexed. Instead of kind of sitting up against the bladder here, it can kind of just be up, not sitting on the bladder, or even a little bit further back or a little further back. But then when it bends on itself, that's when it's retroflexed. So retroverted, retroflexed, antiverted, antiflexed. Okay. So for the ovaries, we already looked at these structures here, but the interstitial portion of the uterine tube, which is right here by the cornua, isthmus, ampulla, infundibulum, fimbria, ovary, this little thin membrane here is called the mesosalpinx. Salpinx being your medical term for uterine tube. And as far as vascularity goes, remember we have the uterine artery, which gives off several branches. So the right ovarian artery comes right off of the aorta, comes down and gives off some branches. So you have the ovarian branch, it's showing it over on this side, the ovarian branch of the uterine artery. You have the vaginal branch of the uterine artery, the uterine branch of the uterine artery here, which looks like it actually comes off of, so wait, we've got this ovarian artery, which feeds the ovary, but then it gets additional blood flow from the ovarian branch of the uterine artery, which actually comes off of the internal iliac artery. So duplicated blood supply to the ovaries because they're that important. And who remembers what's special about the venous supply? Actually, there's also something a little bit special about the left arterial supply, and it's that the left ovarian artery comes off of the left renal vein. And then it follows with the left, I'm sorry, the left ovarian artery comes off of the left renal artery. There you go, Jen. And the left ovarian vein drains into the left renal vein. So when that can create problems, something like pelvic congestion syndrome, where that blood, those veins that are needing to then go into the renal vein and then into the IVC, they can actually get varices, and it can cause what's called pelvic congestion syndrome. So take a look at that. It's a little easier to see on this one. All of these different branches. Then you got the azygos arteries that reach in deeper, feed into the vaginal wall more centrally. And then those very inner arteries within the uterus are those spiral arteries, and they're the ones that shed. So with the menstrual cycle, you have 3 cycles running concurrently. The endocrine cycle, that's where the hypothalamus releases gonadotropin releasing hormones. So that signals the hypothalamus signals the anterior pituitary to release FSH, which is follicle stimulating hormone, excuse me, and LH, which is luteinizing hormone, which then in turn signals the ovary to produce estrogen and progesterone. At the same time, you have the ovarian cycle going on, follicular phase happening days 1 through 5, pre-ovulatory phase happening days 6 through 13, and ovulation at roughly day 14. I say roughly because ovulation can really happen much earlier or much later in your cycle. This is based on a 28-day cycle, but not everybody has 28-day cycles. Anyway, post-ovulation, days 15 through 28 is luteal or post-ovulatory phase. The endometrial cycle only has 2, easy to remember. Proliferative phase, days 1 through 14. The early proliferative phase is where you have that 3-line sign, and the secretory phase is when it's days 15 through 28, when that blood supply is building up, getting ready for the visitor who's coming to sink down into that nice, rich bed of blood. And it is normal to see thickening of 7 to 14 millimeters. I've seen it even thicker than that, and the doctors considered it normal. So we already saw this. These hormones all doing their thing at the same time, creating changes to the ovum, pre-follicle, to mature follicle, to the Graafian follicle, which releases the egg, to the corpus luteum, the late corpus luteum, and finally the corpus albicans. That's what's happening there. Oops. And this bottom one here is the endometrial thickness when all of these other things are happening. Okay. As far as Doppler goes, you have the systolic diastolic ratio, peak diastolic to end diastolic ratio, and this changes also with your cycle. So the Porcelot resistive index, which is also known as the resistive index, is your peak systolic minus your end systolic divided by your peak systolic. Your pulsatility index is your peak systolic minus your end diastolic divided by the mean. The uterine vessels lateral to the cervix and lower uterine segment at the level of the internal os. If you were to Doppler those, your Doppler waveforms within the myometrium are usually high velocity, high resistance pattern. Your ovarian vessels lateral to the posterior border of the ovary are usually high resistance, low flow during the follicular phase. However, if you are, when you are ovulating, it becomes low resistance with high flow. So it's not, the whole point of this is that with any other organ in the body, when you have, you know, like an organ that's being used all the time, let's say like the renal arteries, they are going to have low resistance, high flow. So the ovaries need that during ovulation. So they're using it. They are using that blood flow to help with ovulation. After that's done, it goes back to high resistance. It's like, you don't need me anymore. All right, see you next month. 6. All right. So this follicular phase, you've got high systolic flow, low diastolic flow, which is high, this is high resistance, right? And then when you're moving into that luteal phase, where your ovary is making that corpus luteum cyst to to potentially support a pregnancy. You've got low resistance and high flow. So this is what the waveform is going to look like. This one looks more like the follicular phase. Pediatric gynecology. Precocious puberty is the development of secondary sexual characteristics, gonadal enlargement, so their ovaries start to enlarge, and ovulation before the age of 8 years old. True precocious puberty is gonadotrope independent. So for it to be true precocious puberty, the pituitary has to be involved, has to be creating those gonadotropins, which are signaling the ovaries to mature an egg for ovulation. 80% of the time it is idiopathic. We don't know why it happens. I've told you guys before that this happened to a family member of mine, and they didn't know what happened to her. She had to go on medicine to stop that from happening, because the biggest reason is, well, there's two reasons really, but they stop growing after they get their period, or they stop growing to a large extent. She would have had stunted growth. The other reason is when you guys get old enough to start having mammograms, they're going to ask you, what was your age of onset of your period? And if you're old enough to be in menopause, they'll ask you, like, when did your periods start and when did they stop? The longer that time frame that you had periods, the higher your chances of breast cancer, because circulating estrogen is, one of those risk factors. The longer you have estrogen circulating, the higher your chances of getting breast cancer. So usually caused by an ovarian tumor. I'm sorry, let me go back. Gonadotropin, where are we? We're up here. 80% of the time it's idiopathic. Intracranial tumors, such as a hypothalamic glioma or hamartoma, happens 5 to 10% of the time. Can occur following increased intracranial pressure, i.e. post-meningitis hydrocephalus, treated with long-acting gonadotropin releasing hormones. So they do have meds to treat it. Pseudo precocious puberty is the peripheral type. It is gonadotropin independent. So there's nothing coming from the pituitary to to tell the ovaries to produce and, to mature an egg. Cause is outside the hypothalamic pituitary axis, usually caused by an ovarian tumor, a granulosa thecal cell, most common. Less frequent causes: functioning ovarian cysts, dysgerminoma, teratoma, choriocarcinoma. Adrenal tumor can cause it, although that is rare, and they would scan the adrenal glands. And also a liver hepatoblastoma is at times associated. But the big difference is the pituitary involved or not? The hypothalamus pituitary axis. Okay. Sexual ambiguity. Newborn scan for uterus and vagina. Uterus is small and tubular. Ovaries and testes usually not seen. You can use a high frequency transducer and look in the inguinal canal, or ambiguous labioscrotal folds. Ovaries often have small follicles and testes solid homogeneous texture. If you guys remember Turner syndrome, this only happens to females, is the most common gonadal dysgenesis. And what happens is when the chromosomes, when the egg, the zygote forms, you know, you usually have 46 pairs of chromosomes, but the last one, the sex chromosome, usually you would have XX for a female or XY for a male. Well, it doesn't have both of those genes. It only has one. So they call that 45XO. It's delayed or absent puberty, short stature, webbed neck, renal anomalies, coarctation of the aorta, 45XO karyotype. Just to give you a refresher on what that looks like. Turner syndrome. So you've got that broad webbed neck, no breast development, heart issues, renal issues. So that's what that looks like. Then you can have genetic mosaicism. And that means that not every cell in the body is affected by that absence of that X or Y chromosome. That's called 45XO, 46XX. Ovaries and uterus have varying appearance from prepubertal to intermediate length, remaining smaller than normal. They may have small undetectable ovaries, uterus prepubertal configuration and size, if any, or at any age, if any, and at any age. All right, ovarian torsion. Most torsion occurs within the first 2 decades of life. So between, I guess, babies and 20-year-olds. Normal adnexa in young girls may be very mobile. The right side is 3 times more likely to torse than the left. So torsion happens on the right, congestion or pelvic congestion happens on the left. That helps it all. Clinical symptoms, severe onset of abdominal pain. Sonographic findings, enlargement of the affected ovary, fluid in the cul-de-sac, cyst or ovarian tumor. Many times that ovary is edematous and enlarged. And if you put color Doppler on, you shouldn't see any color flow. It's not good enough to, when you're trying to rule out torsion, to just get an arterial flow. You got to see both flow in and flow out. So you need to be able to see, venous flow as well, because sometimes what happens is with torsion, because those veins are low pressure, they close off first, but the arteries still manage to get a little bit of flow in there. So you've got blood coming in, but nothing coming out. And that's why sometimes they can be enlarged. So this is an example. It does look like that's a kind of a large ovary in relationship to the bladder. And this looks like this, I guess this is maybe cervix, I'm not sure, but you can see it's pretty enlarged. All right, on to what's called urachal cysts. Actually, guys, I'm going to pause just 1 second. All right, we're back. So urachal cysts. So you can have an opening between the urethra and the umbilicus or belly button. So basically there's like a channel that goes from the bladder, and you can actually have urine escaping from the umbilicus. And it's called, when that happens, it's called a urethral cyst. Well, here, this is called a cyst. So urethra, bladder, little channel opening, you have a cyst, and then a little channel again. So this is called a patent urachus, where you just have a direct link to the outside of the body here. This is a vesico-urachal diverticulum. So vesico meaning bladder, and a diverticulum is an outpouching. So you have this diverticulum that has this connection to the belly button. Then you have a urachal sinus. That's where you have this inpouching of this invagination of the belly button or umbilicus that has an attachment to the bladder, and then this urachal cyst. So if you're ever asked to scan for, urachal abnormalities, that's what you're doing. You're looking for some sort of connection between the bladder and the belly button. So it is the persistence of an embryonic urachal lumen between the dome of the bladder from umbilicus, normal urachal remnant in 62% of bladder sonograms in children, small cyst posterior to the rectus abdominalis muscle. Anyway, so if you're scanning and you've got the bladder, it's going to be kind of anterior to that. So like so. All right, intrauterine contraceptive devices, also known as IUDs. You've got Mirena. You've got more now too, since this was made up. There's lots of other kinds and brands and sizes, and not so much the size, but the amount of hormone that's embedded in the plastic. So Mirena, being T-shaped, releases hormones for 5 years. It sits up into the opening of the uterus, and it kind of tension holds it in place. You have Paragard, which is copper and T-shaped here. You have Progestacert, which I have never heard of before, but it is T-shaped and releases progesterone. Copper T, copper 7, still seen in the US, no longer being inserted. So there's no new patients getting these, but you could potentially have a patient that has one. You have Lippy's loop, which is this spirally thing here, also still seen in the US, but no longer being inserted. 5 loops giving 5 acoustic shadows. Dulkin shield, oval with small legs, removed from the market in the US due to repeated pelvic infections. And the appearance is going to be highly reflective, echogenic linear structure in the mid endometrial uterine body. Sometimes you can see these sitting too low. I'm sure you guys have probably seen this in clinic. Where it kind of slips down out of place, like that, or like this. Worst case, it can perforate. Which means that it has infiltrated the myometrium. See, you can see here. Here's the endocervical endometrial canal, but this is in the myometrium. So somebody's coming in complaining of a lot of pain with their IUD, you want to check that out. See whether it's going along with the contour of the endometrium or whether it's, you know, here. Okay. Infertility and endocrinology. So the inability to conceive after 12 months of unprotected intercourse is considered infertility. Been trying for a year with no luck, you are considered infertile. However, it could be the male's fault, not fault, but it could be, you know, the infertility could be on the part of the male. It's not always the female. So 40% of the time, it is due to decrease in decreased or abnormal sperm production or motility, an obstruction or absence of epididymitis, or epididymis, I mean, the vas deferens or ejaculatory duct. So there could be a structural issue, large varicocele, it could be idiopathic, but if there's a structural or physiologic reason that the male is not producing or being able to transfer the sperm, then that's male factors. For females, there could be a tubal obstruction. So if there's a tubal obstruction, obviously, then not only can the egg not get from the ovary into the tube, but the sperm can't get from the uterus into the tube. So that can come from PID, pelvic inflammatory disease, endometritis, implants, adhesions. It could be ovarian failure, abnormalities or absence of vagina, cervix, or uterus, nutritional factors, metabolic factors, ovarian disorders. 5 to 10% of the time, both partners, and 5 to 10% of the time, it's unknown reasons. So infertility treatment includes hormones, Clomid, HCG, Pergonal, which is FSH and luteinizing hormone, ovulation induction, follicle monitoring. Dominant follicles should measure 1.6 centimeters. Ultrasound monitoring for follicle aspiration, timing of HCG, timing of intercourse. Yeah, so they can actually harvest the eggs. So they go in and aspirate out those eggs. So you could potentially, you know, be asked to help with that. Your ultrasound assisted harvesting. Assisted reproductive technology, IVF, which is what? In vitro fertilization, embryo transfer, follicular aspiration, gift and zift, artificial insemination, sperm is washed, optimized, placed in the uterine fundus. Does anybody remember gift versus zift? So what happened to my chart? So GIFT stands for gamete intrafallopian transfer. So A laparoscope is used to aspire one or more mature oocytes from ovarian follicles and transfer the oocytes and sperm to the fallopian tube. It is more invasive than IVF, usually for patients with religious or personal reasons do not wish to have embryos in the laboratory. It is also appropriate for those who have failed donor insemination or require laparoscopy for other reasons. Then you have ZIFT, which is zygote intrafallopian transfer or tubal embryo transfer. So this procedure involves the placement of fertilized eggs, known as zygotes, or embryos into the fallopian tube. So GIFT, they are taken and put into a so they don't fertilize the egg. They kind of put them together and let them do their own thing. Whereas ZIFT, they actually fertilize the egg and then insert it once it's already, once it's a zygote, once the two cells fuse. So that's the difference there. Complications, ovarian hyperstimulation syndrome, high levels of HCG, hypotension, polycythemia, large multiple ovarian cysts, pleural effusion, and ascites. Have you ever seen hyperstimulation, ovarian hyperstimulation on ultrasound? Looks like that. It's crazy looking. Looks like a polycystic kidney or something. But it can cause a lot of complications. You could also have multiple gestations. More common to have an ectopic pregnancy. Fertility patients are at higher risk for ectopic. So ovarian hyperstimulation syndrome is a complication of ovarian induction. In mild OHS, you're going to have pelvic discomfort, enlarged ovaries, less than 5 centimeters, no larger than 5 centimeters, or severe pelvic pain, abdominal distension, ovaries enlarged to greater than 10 centimeters, ascites, pleural effusion, and it does resolve with treatment within 2 to 3 weeks. All right, so this is an enlarged ovary with multiple complex cysts. What does this have the look of? Remember what that kind of looks like? That like webbing kind of looks like a hemorrhagic cyst a little bit. This is free fluid in the intraperitoneum, the intraperitoneal cavity. Another example here. You'll know it when you say it. It's not subtle. Okay. Postmenopausal gynecology. The uterus shrinks, retaining a pear shape. Fibroids will shrink. Why does the fibroid shrink? I'm sorry. They're estrogen. They grow with estrogen. They're estrogen dependent. And when somebody goes through menopause, their body's not making estrogen anymore. Well, for the first year, there's fluctuating levels of estrogen. But then after, who remembers when is somebody officially in menopause? It's when they haven't had their period for 12 months consecutive. After that, those estrogen levels start to level out. They're low, but they do level out. And women who are having those hot flashes and mood swings and all that, that gets better once the levels are stable instead of fluctuating. Endometrium less than 8 millimeters. Well, I gotta disagree with that. It's actually less than 5 millimeters unless they are undergoing hormone replacement therapy. So let's just check that. Postmenopausal endometrium. Abnormal. So upper limit is less than 5 millimeters. The risk of carcinoma is approximately 7% if the endometrium is greater than 5 millimeters. Versus 0.07% if the endometrium is less than 5 millimeters. If they are on hormone replacement therapy, upper limit is 5 millimeters. I think this is actually 8 millimeters. So. No history of vaginal bleeding. Oh, I'm sorry. If there is vaginal bleeding, and they are on hormone replacement therapy, it is still 5 millimeters. If there's no history of vaginal bleeding, it can be up to 11 millimeters with the same, roughly that same chance of carcinoma, approximately 7%. So if on tamoxifen, which is a treatment for breast cancer, it should still be less than 5 millimeter, although roughly 50% of those receiving hormone replacement therapy, tamoxifen, have been reported to have a thickness of greater than 8. So normal with no hormone replacement therapy should be less than 5, not less than 8. Less than 8 if they're on hormone replacement therapy. The ovaries shrink in size, simple ovarian cysts with little change. So you don't have a maturing Graafian follicle anymore. They're just small, nothing's happening with them. They're not maturing and growing or anything like that. So postmenopausal pathology, if you have vaginal bleeding, you could have poorly controlled hormone replacement therapy. They could have endometrial polyps, submucosal or intracavitary fibroids, endometrial cancer, endometrial atrophy. ES, endometrial, I don't know what S is, less than 4 millimeters throughout. Endometrial stenosis, maybe? Endometritis. If they have a thickened endometrium, well, of course, if they are not at that 12-month mark and they're still in perimenopause and getting periods, it could just be normal. Early intrauterine pregnancy or complications with an ectopic, again, in perimenopause. They could be on tamoxifen therapy, endometritis, blood in the endometrial cavity, benign endometrial hyperplasia. So if they are officially postmenopausal and they have a thickened endometrium, it doesn't necessarily mean it's a carcinoma. It could be that benign endometrial hyperplasia, but the doctor wouldn't know for sure unless they did a biopsy. So Pretty much if a woman comes in and they're at 5 millimeters, they're getting a biopsy because they want to see what's causing that thickening. Could be polyps, fibroids, hormone replacement therapy, or endometrial cancer. Postmenopausal uterine pathology, that benign endometrial hyperplasia can cause irregular bleeding, thickened endometrium, tiny cysts within the endometrium. Endometrium polyps are often asymptomatic. They may bleed. They often will have multiple. Focal echogenic mass in the endometrium, almost always benign. Do you remember what you'll see a lot of times with those polyps? You'll see some sort of like a feeding vessel. And do you remember that test that they'll do? What's it called? It's the when they infuse saline in, yeah, something, saline infusion, polyps. SIS, saline infusion, sonography, there's another word for it. Oh, sonohysterography? No, wait. Maybe. All right, well, I might have to get back to you on that. Hysterosalpinography, doesn't matter. Anyway, there's a procedure that they can inject saline, and that'll give a nice outline to see whether there really are polyps. Endometrial cancer, common GYN cancer, can find uterus in 75% when initially diagnosed. The appearance can be a thickened endometrium, polypoid mass, low impedance, color flow. So we were talking about how, you've got that low resistance, high flow Doppler waveform. Well, cancer's thirsty and it's going to take a lot of blood. So you'll have a low resistance waveform on that as well. Risk factors: obesity, chronic anovulation, hormone replacement therapy, early menarche. Remember I was saying about how the longer you have circulating estrogen through your body, the more the more high risk you are for cancers. So early menarche, late menopause, obesity. It's interesting why obesity is a risk factor. And I actually just found this out not that long ago. It's because estrogen is stored in fat tissue. So the more fat cells you have, the more estrogen you have in your body. That's also why a lot of times women who are obese go through menopause a little later in life. Ovarian cancers are cyst adenocarcinoma. That is the most common type. It's often bilateral. You will see an irregular outline with papillary projections internally and peripherally. You could see mets to the liver, para-aortic nodes, and peritoneal cavity. Does anybody remember para-aortic nodes? Is when you see those enlarged lymph nodes around the aorta and mesenteric vessels. It's the sandwich sign. Remember, I don't know if you remember, you've got the aorta and you've got what's supposed to be the SMA that's kind of like right up against it, but it'll be like up like this and it'll have those circular, solid appearing masses. And then these projections, papillary projections, that's neural nodules. So this little growth that's that's growing into the ovary, that is not a good sign. If you have vascular septations, so the more septations and neural nodules, like these growths, the more chance it is a carcinoma. You can have a granulosa cell tumor, which is a rare tumor with low malignant potential. It produces estrogen, mainly in postmenopausal women. It can be multilocular, cystic, or solid. Steroli Leydig cell tumor, which is called an arenblastoma. It's a masculizing tumor, similar in appearance to a granulosa cell tumor. And then you could have dysgerminoma, which is a rare stromal tumor. Women 20 to 30 years old. It grows rapidly, highly malignant, ovoid, smooth, solid, homogeneous. And then Krukenberg tumor, pelvic nets from the stomach, from stomach cancer, bilateral, smooth-walled, hypoechoic. But this cysadenocarcinoma is, or cystadenocarcinoma is the most common type. Yeah, sure. Then you can have pelvic pathology, congenital uterine malformation. Remember those? Those are those. That's these. Uterine didelphys, arcuate, unicornate, only one cornua, bicornuate, septate. You remember which one is the greatest incidence for infertility?
I
I think it's septate.
Oh. What?
I'm pretty sure. Hold on. Hold on. This thing gonna make a liar out of me.
I have to go reread all of my notes. Yes.
I know, it's so much.
I don't know where they went.
I'm gonna have to get into the slides and look, because I'm not. Septate, I thought it was septate, let's look, septate uterus. All right. Septate uterus doesn't normally cause problems with conception, but it does interfere with your ability to carry. In fact, up to 40% of women with septate uteri have miscarriages. So, you know what, I could be confusing infertility with inability to carry. And hopefully it'll be in here somewhere. Anyway, so this pelvic pathology can include these congenital uterine malformations, uterine masses, which can be malignant or benign, fibroids, adenomyosis. Who remembers adenomyosis? What is that? It's a type of endometriosis, but it is limited to the myometrium. So it is basically endometrial tissue within the myometrium. Nabothean cysts, I don't know that I'd call that pathology, but pretty much everybody has that, but they're not harmful in any way. I imagine as long as they stay small, I guess if they got big enough, they could cause a problem. Cervical cancer, endometriosis, which is endometrium that can actually grow into the bowel. It can grow into the ovary. It can wreak all kinds of havoc. AV malformation, endometrial hyperplasia, endometrial polyps, endometritis, which is a infection within the endometrium. Synechia, which is scar tissue, correct? Synechia, I'm pretty sure. Ovarian masses that are benign can include benign cystic teratomas, cystadenomas, stromal tumors, and then PCOS. You guys have to remember teratomas. They're probably one of the most interesting things ever. Can be composed of,
Is that like the hair,
Yeah.
and the teeth, and all that?
yeah,
weird stuff?
it could be composed of all 3 germ cell layers. So it could have hair, bone, fat, whatever. It literally means, the etiology of that word is monster tumor. Because I guess when they first saw it, it looked like a monster. PCOS, you guys all remember PCOS, right? Polycystic ovarian syndrome. And that is when the ova within the ovaries never mature. They don't develop, and then there's no ovulation. Pelvic inflammatory disease, para-ovarian cysts, peritoneal inclusion cysts, and Gardner duct cysts. So Gardner duct cysts happen where?
The vagina.
In the vagina, right? Yep. All right. Congenital uterine malformations. You can have vaginal atresia or imperforate hymen. That would cause, so imagine if the exit is blocked and you get your period, where's it going? So you could have, if it's an imperforate hymen, there's no opening there, or if it's vaginal atresia and it's too narrow for the blood to exit, you could end up with hematocolpos. Remember, colpos is vagina, hemato blood, so blood-filled vagina. Hematometria, which is a blood-filled uterus. Hematocolpometria, blood-filled vagina and uterus. And of course, this is with the onset of menses. In utero, fluid-filled vagina or uterus is hydro in utero fluid. Hydrocolpometria. So, okay. So I guess we're talking about fetuses here in utero fluid filled vagina or uterus. Hydrocolpometria. All right. So,
Greg,
How are you, buddy?
good.